Duk-Woo Park, Jung-Min Ahn, and Mike Gibson coming to you live from ACC 2024. And we're talking about a very, very exciting trial. I'm excited to hear this one, the PREVENT trial. Talk to us about what you did.
So I think that the PREVENT trial, the first large size, the random trial, the vulnerable plaque for the last 20 years, and the optimal medical therapy was the cornerstone of the management of a vulnerable plaque. And this is a first large size clinical trial to compare the preventive PCI for vulnerable plaque versus optimal medical therapy. And so we included more than 1,600 patients is the absolutely power to detect the relevant outcome.
Amazing. We've always wondered about that 30% stenosis, and if it was full of fat and had a thin fibrous cap, we were leaving it behind, but you intervened. So that's very, very, very exciting. So, Jung-Min, talk to us about the protocol.
Yes, actually, we define the vulnerable plaque by intracoronary imaging. We know the patient who have coronary artery disease or suspected coronary artery disease. If a patient have non-flow limiting coronary artery stenosis, angiographically more than 50%. Non-flow limiting means FFR is negative, more than 0.8, or then we evaluate the intracoronary imaging. Depend on the situation. So we define the vulnerable plaque by the intracoronary imaging. The 2 out of 4 imaging criteria. One is a minimal lumen area less than 4 square millimeter, or plaque burden is more than 70%, or sphincter fiber atheroma by OCT or RF-IVUS, or lipid-rich plaque by the NIRS. Maximal lipid core burden index more than 315. So if the lesion met the 2 out of 4 criteria, we define it as a vulnerable plaque. So we randomly assign to the 2 groups. One group is a preventive PCI group. The other is optimal medical therapy alone group. So we follow this patient. The primary endpoint is at 2-year MACE, including the cardiac death, target vessel myocardial infarction, ischemic-driven target vessel revascularization, and rehospitalization due to progressive angina.
What did you find?
So the primary endpoint at 2-year MACE, target vessel failure. We found that in preventive PCI group, the event MACE occurred in 3 patients, 0.4%, and OMT group, the event rate event occurred in 27 patients and 3.4%. So we found that preventive PCI significantly reduced the rate of primary endpoint of target vessel failure, compared with optimal medical therapy alone.
Wow. So that was about am I getting it right? A 3% absolute reduction? Is that correct?
Yes, right.
Wow. So
At
you
2
wouldn't
years.
you wouldn't need to treat that many people, only 33 people or so to prevent one target vessel failure. That's amazing. Yes. What else did you learn?
So we also follow up to the median 4.4 years. So during the extended follow-up period, the main finding is sustained up to median 4.4 years. So every subgroup analysis, secondary outcomes, including cardiac death and target vessel MI or other composite endpoint, show that the similar signal. The preventive PCI show that the decrease the risk of MACE during the long-term follow-up.
Amazing. So, Duk-Woo, does this change things? I mean, does this change practice? Do we need more studies? Tell us what we make of all this.
Yes, I think the most of interventional cardiologists as well as the general cardiologists, after hearing the primary result, the Prevent trial would be shocked in the, we are now, and most of the background trial, ischemia trial in the optimal medical therapy would be okay in patient in the even obstructive coronary artery disease. And I think a Prevent trial is the first trial to demonstrate superiority, statistically also significant of a preventive PCI and compared to the medical therapy. So I think what is next? So, and one of the interesting in our Prevent trial and more than 75% and the stable angina, 25% was acute coronary syndrome. So what we do is clinical application of the clinical trial, the still is questionable. And what we screened, how do we screen the patient, and how do we follow? And that is the next, the research topic is, the real practice. We do a lot of patient CT screening, and we cannot do every patient's the intravascular imaging modality for all patients. So which patient would be optimally treated well with preventive PCI, and that is our next target of the research.
Well, in ischemia, you had flow limiting stenoses. Those may be pretty stable, right? I mean, they may cause ischemia, but they may not have plaque rupture. You looked at a whole different population that may be at a higher risk of plaque rupture, but may not be causing ischemia. And of course, it's that plaque rupture that's going to cause an MI. So in my mind, it may not be that hard to reconcile the difference in results between the two trials. Well, I know we had pitched a trial like this to different sponsors. You guys pulled it off. I'm very excited to see what you found. Congratulations to both of you and all the investigators. We look forward to more from you. Thanks, you two. And thanks to all of you
Thank
for
you.
joining us here live from ACC.
Thank you.
Thank you.
Mhm.